Hello everyone, I am Dr. Sarvana Santosh Kumar, and today in this session we are going to discuss the mock exam INI SS neurosurgery part. That is the third grand test that we had conducted about a week ago, and we are going to discuss the 55 neurosurgery questions which were asked in this exam. So the main aim of this discussion is to help you understand certain nuances and to help you to solve the MCQs easily, and also to discuss about some very important details. So with this introduction, I'm getting into the slides. So the first question that was asked was, all are predisposing causes for cerebral venous thrombosis except. So what is very important to understand is that cerebral venous thrombosis is caused by certain conditions which are going to increase the viscosity of blood and also the thrombogenic factors. So anything that is going to increase the viscosity or thrombogenicity of the blood, then it is going to result in cerebral venous thrombosis. The common setup in our Indian culture is people who are alcoholics, the chronic alcoholics who are in constant dehydration, hypotension, and they tend to develop this CVT, especially young adults, and especially even after episodes of diarrhea, young people in their early 20s are predisposed to develop CVT. And other important causes are pregnancy, oral contraceptives, hypertension. But what among this is not a cause will be aplastic anemia. So aplastic anemia is not a thrombogenic situation, so it is not going to cause a CVT. So some important things that you have to remember, apart from what we have told, is one is infection and cardiac diseases, including congestive heart failure, polyarteritis nodosa, sickle cell trait. So all these have a very high tendency to cause a CVT. And diabetes mellitus, along with ketoacidosis, especially the DKA setup, homocystinuria, and Behcet syndrome. So all these have a tendency to cause increased CVT. So all the other causes, you know, I'm not stressing on them. The second question is the most common site of hypertensive intracranial hemorrhages. So you know the answer, it is putamen. This has been asked time and time again. It is a very famous repeat question. So I hope you know the answer. The answer is going to be basal ganglia, and among that the putamen will be the most common site. So basal ganglia will be the most common site. And the most common cause, as you know, is hypertension due to rupture of small perforating arteries. It is called as bilioaneurysms. And worse prognosis for patients on anticoagulants or with elevated cardiac troponins. So when do you need to do additional diagnostics like CT angio or catheter angiogram or a MRV? If you suspect an underlying anomaly, abnormality like AVM or dural venous thrombosis or neoplasm. So when will you suspect these? When it happens in an unnatural location. So the most common cause is always going to be basal ganglia. After that, it can happen in pons or thalamus. These are, or sometimes in the lobes, that is in the parietal lobe, something like that. So when these are the usual locations, when it is going to happen in unusual locations, then you will have to think about other causes. For example, tumor, or even an AVM, or even a dural sinus thrombosis, especially when you identify a hyper dense superior sagittal sinus in the CT, then you'll always have to keep in mind a CVT and you have to rule it out. And hypertension, especially when the systolic blood pressure is more than 150 millimeters of mercury, and even when you are treating it, you will have to reduce it to around 140 millimeters of mercury. You should not reduce it drastically. And role of surgery. Regarding role of surgery, see, the supratentorial ICH, still it is a controversial thing, whether surgery is going to improve the patient or not. But one thing it does do is, it reduces the length of ICU stay and mortality. If done at the right time, you decompress or you suck the clot at the right time, then it reduces the ICU stay and mortality. Why it is still controversial is because most of these patients die because of end renal failure. Just like hypertensive ICH is happening, at the same time hypertension also damages the kidney. So, and we give mannitol Lasix inadvertently. And even though we monitor, but they have a tendency to go for hypertensive nephropathy at a very rapid stage. So that's why their survival is not that good. And what about cerebellar ICH? Cerebellar ICH, the chance of neurological iteration and brainstem compression is very high. So when you see a cerebellar ICH, and if the volume is more, if it is going to compress on the fourth ventricle, then it is a neurosurgical emergency. Then it is going to be a neurosurgical emergency. So you have to treat it. You have to do a suboccipital craniotomy. You have to evacuate the ICH. Only then the patient is going to survive. Now, a 69-year-old male was admitted in the neurology unit who complained of severe discomfort of the lower back. The radiologic examination of the lumbar region showed significant narrowing of the spinal canal caused by advanced osteoarthritis. The back pain became more severe and is now radiating to the left leg. Patient is experiencing difficulty in walking. Examination shows weakness and wasting of muscles on the left leg. Radiological examination is showing you osteoarthritic changes involving the boundaries of many lumbar intervertebral foramina. Explain the change in symptoms and signs found in this patient. So is it due to a rectal cancer compressing the sciatic nerve? Or is it because of advanced atherosclerosis of the arteries of the right lower limb? Or is it because of osteoarthritic changes resulting in osteophytes that encroach on the intervertebral foramina, compressing the segmental spinal nerves? Or is it because of neuritis developed in the sciatic nerve? So all these can be differential diagnosis, but it is very clearly given you that it is an osteoarthritis. So what happens in osteoarthritis is that it is going to cause something called as a bamboo spine. So that osteoarthritic process is going to produce osteophytes, which are going to encroach on the intervertebral foramina and compress the segmental spinal nerve roots and result in claudication pathology. So it is classically the lumbar canal stenosis that has been described. So what is explained here is the claudication pain, the radicular pain, and the wasting happening because of denervation, because of the compression of the nerve roots. And that claudication pain is because of the nerves crying out of the compression, because the nerves cry out of compression. That is why as they continue to walk, that as when you are going to walk, there is going to be some extension of the back, and that extension is going to narrow the already narrowed intervertebral foramen. So that is why they have a tendency to have claudication pain. All right. So true about berry aneurysms is of all of the following except. So berry aneurysms, like I told you, they are tiny aneurysms. They happen in hypertensives, and they can be associated with familial syndromes. And the most common site of rupture is always the apex or the dome of the aneurysm. That is always going to rupture and is going to cause SAH or ICH or IVH, whatever it could be. And majority of the aneurysms will happen in the anterior part of the circulation at the branching point. What is not true is that it will not contain smooth muscle fibroblasts. So that is not true. It is not going to contain smooth muscle fibroblasts. So that is going to be the answer after excluding all. So predisposing factors, smoking and hypertension. Pregnancy is not an independent risk factor for aneurysmal SAH. Wall of berry aneurysm is made up of thickened hyalinized intima. The adventitia covering the sac is continuous with that of the parent artery. And this is a very, very, very important slide. So ADPKD, Ehlers-Danlos syndrome, NF1, Marfan syndrome, fibromuscular dysplasia, coarctation of aorta, all these are going to be risk factors for berry aneurysm. And rupture will usually happen at the apex, resulting in SAH or IVH or ICH. And that is about the berry aneurysms. Next question is, a 75-year-old male is complaining with problems of his gait, urinary incontinence for the past 6 months, and recently his short-term memory is becoming problematic. So when he started to walk, he is having a magnetic but normal arm swing. So magnetic gait with a normal arm swing. And the mini mental state examination is 27/30. The CT head has shown dilated ventricles. The CT brain is showing dilated ventricles. So which one of the following is the next appropriate step in management? This topic is very, very, very important. So what has been described here is the classical normal pressure hydrocephalus. So the triad, that is what is called as Hakim-Adams triad. The triad will be, you remember the mnemonic DAI, dementia, gait ataxia, and I is for incontinence, urinary incontinence. So this will be the classic triad. And the first to go will always be the gait. Okay, the first to go will always be the gait. And the most resistant will be the urinary incontinence for recovery, even after the shunt, even after successful shunting, the last to recover will be the urinary incontinence. And similarly, the gait will be the first one to recover very early. So how will you, what is the next appropriate step? So once you establish the diagnosis of NPH, the next thing is to confirm that it is NPH. How do you do it? You do it by doing a lumbar puncture tap test. So what is meant by lumbar puncture tap test? You tap, you do a lumbar puncture, you take out 330 ml of CSF for 3 consecutive days. So 30 ml of CSF for 3 consecutive days, you let it out and you examine for any improvement in gait. If the diagnosis were to be NPH, then you will certainly find a improvement in these patients. Then you go on to do a thecoperitoneal shunt or a ventriculoperitoneal shunt if the ventricles are enlarged. Okay. So the next step will always be a lumbar puncture test. So like I told you, it's a classical triad of gait ataxia, gait apraxia, dementia, and incontinence. And performing a large volume lumbar puncture, draining 30 to 50 ml for 3 days is going to be diagnostic. And in those cases, when the lumbar puncture fails or is contraindicated, then a ventricular reservoir can be inserted and testing can be repeated after a few months. So gait in these patients is classically described as being magnetic. So what happens is they will walk as if they are stuck to the floor with a broad base, slow, small steps, and reduced height clearance. So very much confused with Parkinsonism. And urinary continence may be neurological or consequence of gait disturbance or cognitive impairment. So which one of the following approaches is least likely to be appropriate for management of entrapped fourth ventricle? So what is meant by this entrapped fourth ventricle? See, the fourth ventricle gets trapped, meaning it is not communicating with the cerebral aqueduct or with the outlet forces. That is the foramen of Laschka and Magendie, and it is acting on its own. It is getting dilated. So this is quite common scenario, especially in children who have repeated shunt dysfunctions and have multiple shunts, who have had multiple shunts. In those scenarios, you can encounter this phenomenon of entrapped fourth ventricle or the trapped fourth ventricle. In that scenario, which among the following is the least likely appropriate for management? See, a fourth ventriculoperitoneal shunt can be done. Though it is difficult, it can be done. Endoscopic aqueductal stenting, which is the treatment of choice in the present scenario, and a lateral ventriculoperitoneal shunting can be done. Or you can do an endoscopic third ventriculostomy and do an aqueductoplasty. That is, you dilate the cerebral aqueduct. That is one way to do it. But what is not advisable or is not being done is the foramen magnum decompression with expansive duroplasty. So this is not commonly done. So this is the treatment. That is a foramen magnum decompression, and the expansion duroplasty will be the treatment for Arnold-Chiari malformation. That will be the treatment for Arnold-Chiari malformation. So a 10-year-old child is having a large head since long term, and the CT brain suggests a large ventricle without CSF oozing. So 10-year-old child is having an abnormal head for a very long time, and CT brain is suggestive of large lateral ventricles without CSF oozing. So at present, patient is blind. So what is the least possible cause of blindness? See, hydrocephalus can cause blindness. In what ways? One, by occluding the posterior cerebral arteries, PCAs, bilateral PCAs, they can get occluded because of a transtentorial herniation, and it can result in visual cortex infarcts, which is very rare, which is quite rare, but still can happen. And that can result in blindness. Okay, that can result in blindness. That is why you get this Anton syndrome, Balance syndrome, all this stuff. Then you have chronic papilledema because of untreated hydrocephalus and resulting in secondary optic atrophy. So it is going to result in primary optic atrophy. The optic nerve undergoes atrophy because of papilledema. So that can result in blindness. And one other reason is quite rare, but it can still happen. One, that is, it is the dilated third ventricle can sometimes compress on the optic chiasm. And as the compression effect increases, it can result in blindness, complete blindness. That we usually feel defects in the initial stages, but if left untreated, it can result in blindness. So these are the three possible causes. What cannot cause is going to be occlusion of ophthalmic artery. It is not going to occlude the ophthalmic artery, so it is not related to hydrocephalus. Of course, ophthalmic artery occlusion can result in field defects and visual and blindness, but not because of hydrocephalus. So that is why it is after ruling all other options out, we get to the answer as option C. So what is Hakim's-Adams triad? Like I told you, the Hakim's-Adams triad will always be altered mentation, that is dementia, gait difficulties, and sphincter disturbances, that is the urinary incontinence. So in any form, if they ask, you're going to answer it right. So it was named after this Hakim, and the term normal pressure hydrocephalus was introduced by Hakim in his thesis paper in 1964. The concept was introduced in English literature by Adams et al., in which Hakim was an co-author. It was published in the New England Journal of Medicine in 1965. A little bit of history that if you want to remember. A 5-year-old child presented with nausea, vomiting, and headache in emergency department. CT brain is showing hydrocephalus. So which among the following is the best treatment? See, all this can be done. VP shunt, VA ventricular pleural shunt, and very rarely this ventricular-cisternal, no one is doing much. But all the other options A, B, and C can be done. But the one that has tested time and has stood against decades is always going to be a VP shunt. So even now, VP shunt will be the first step that you are going to do if you do not have the setup of an endoscope. So in that scenario, you can do endoscopic third ventriculostomy. Otherwise, the ventricular peritoneal shunt will be the first step in managing these patients. So diurate hemorrhages are seen in. See, this is a trick question. Diurate hemorrhages can be seen in pons or medulla. So it can happen either in pons or in medulla. It can happen in both. Why it happens? It happens because of transtentorial herniation, because of central herniation caused due to some supratentorial problem. The raised supratentorial pressure will cause the brainstem and the mesial temporal lobes to be forced down through the tentorial hiatus. As a result, it is believed that the perforating branches of the basilar artery and the draining veins are damaged, resulting in parenchymal hemorrhage. It is usually seen in patients with severe herniation 12 to 24 hours prior to death. So it is a sign of irreversible brain damage. It is going to be a sign of irreversible brain damage. The next question is the meningohypophyseal trunk. The meningohypophyseal trunk is a branch of which segment of ICA? So you have to know about the various segments of ICA. Okay, so you know there are going to be 7 segments, and the meningohypophyseal trunk will be a branch out of the cavernous segment. So the cavernous carotid is going to give one other important artery. It is called as McConnell's capsular artery. This has been asked previously in exam, so you have to know this. And the inferior cavernous artery and the meningohypophyseal trunk. The meningohypophyseal trunk will give rise to dorsal meningeal artery, inferior hypophyseal artery, and the named artery, otherwise the Italian artery, named after Bernasconi and Casinari, is nothing but the tentorial artery. So the tentorium will be supplied by the tentorial artery, which in turn is a branch of the meningohypophyseal artery, which arose from the cavernous carotid. So C4 segment is going to give rise to tentorial artery. You have to remember this. This has been asked. Both the McConnell's capsular artery and the tentorial artery of Bernasconi and Casinari, both of these have been asked in exams previously. The petrous carotid will give off the Vidian artery, caroticotympanic artery, and occasionally the stapedial arteries. And the ophthalmic segment is going to give the ophthalmic artery and the superior hypophyseal artery. Then you have the communicating segment, which is going to produce the posterior communicating artery and anterior choroidal artery. So all these are the various branches of the internal carotid artery. So less common type of hydrocephalus in children is always going to be post-traumatic. So hydrocephalus can happen with brain tumor, especially in the setting of medulloblastoma, pilocytic astrocytoma, it can happen. It is usually associated with myelomeningocele. That is why in Chiari-2 malformation, you end up with myelomeningocele and hydrocephalus. And in IVH in premature newborn, especially these children are prone for this germinal matrix bleed. In that scenario, they can develop IVH, which can result in obstructive type of hydrocephalus. So all this can cause hydrocephalus, but not trauma. So trauma, very rarely. Trauma is a less common type. So this is a very important question. Which among the following pathologies is most likely to give the appearance shown as below? So this is how a string of bead appearance happens in fibromuscular dysplasia. So this is how the fibromuscular dysplasia is going to look like. So fibromuscular dysplasia, especially in middle-aged women, most commonly affects the cervical internal carotid artery, and the vertebral and external carotid artery can be involved, but quite rarely, not very common. And what is very important is the angiographic images is going to show you a string of bead appearance. This is nothing but the corrugation, which typically affects the middle segment of the internal carotid artery, usually 2 centimeters distal to the bulb. So unilateral or multifocal tubular stenosis are less common, and FMDs can be occasionally observed intracranially, and especially when they are associated with aneurysms. So what you have to remember here is the MCQ point for you will be the string of bead appearance. So events ratio. So what is the cutoff? The cutoff will always be 0.3. Anything more than 0.3, we call it as hydrocephalus. So events ratio, it was originally described for ventriculography. It is nothing but the ratio of frontal horn diameter to the maximal biparietal diameter measured in the same CT slice. So if it is more than 0.3, it is going to suggest you hydrocephalus. A 6-year-old child is presenting to you with pineal region tumor, presenting with vomiting and upgaze palsy. What is the possible cause for the setting sun sign in this patient? So apologies for the typing error here. It is sign. So what causes this upgaze palsy? That is the question. So the upgaze palsy is happening because of compression in the region of the suprapineal recess. So the suprapineal recess, that is the dorsal midbrain, when that gets compressed, that is the superior colliculus, that is very adjacent to the suprapineal recess. So when that gets compressed, the child has a tendency to develop an upgaze palsy. In a hydrocephalus patient, all are CT or MRI criteria, except the size of the both temporal horns, it should be more than or equal to 2 mm in width. Periventricular low density on CT or periventricular high intensity signal on MRI, suggesting transependymal absorption. Third ventricle should be slit leg. So that is going to be the exception. Third ventricle will be ballooned out. Events ratio more than 0.3. So all of these are CT or MRI criteria, except the third ventricle, which should be rounded. Ballooning of third ventricle will be the classical picture. So you know that the temporal horn diameter, it should be more than 2 mm in width in the absence of hydrocephalus. The temporal horns are very rarely visible. And if it is more than 2 mm and the ratio of frontal horn internal diameter, if it is more than 0.5, then it is going to be suggestive of hydrocephalus. Other features will be the Mickey Mouse ventricles. That is nothing but the ballooning of the frontal horn of lateral ventricles, or the third ventricle ballooning, the periventricular low density, that is hypodensity, or if you look in the MRI, it will be a hyperintensity, which is suggesting a transependymal CSF flow. That is that is a very important type of edema. Okay, so that is the interstitial edema. And if used alone, the frontal horn internal diameter ratio, it is less than 40% is normal. More than 50%, that is 0.5, 0:5. That is suggestive of hydrocephalus. And events ratio, I already told you, it should be more than 0.3. Events ratio is a very important MCQ. That is it is the ratio of the frontal horn and the maximal biparietal diameter. That ratio, if it is more than 0.3, and a sagittal MRI showing thinning of corpus callosum or an upward bowing of corpus callosum. So all these are features suggestive of hydrocephalus. Now, the next question, a mother comes to you with the CT brain of a 6-month-old child, and the CT brain is suggesting enlarged subarachnoid spaces where frontal poles and the ventricles are normal. What is this condition called as? Is commonly encountered, especially in this scenario, in this present situation where for medical legal purposes, we take CT for every trivial fall. So in this scenario, you can very commonly encounter a 6-month-old child or a 1-year-old child while playing has a tendency to fall, hit over the head and cries. And suddenly parents come to you telling that the child has an LOC for a few minutes and you are afraid. Or let's say to be, let's not put the word afraid, it's quite scary. Let's use the word, they are convincing you to take a CT. They want a CT to be done. So in that scenario, out of pressure or even out of not taking a precaution to rule out the worst outcomes, we subject children for CT scans. In that scenario, this can happen very commonly, where the subarachnoid spaces are enlarged and the ventricles are normal. So this is what you call it as an external hydrocephalus. So this is not going to be a significant finding. It will resolve on its own. The enlarged subarachnoid space, as a child matures, that the subarachnoid spaces will come back to normal and the ventricles will always be normal. So it is going to be called as external hydrocephalus, and it doesn't require any sort of treatment. So external hydrocephalus is nothing but an enlarged subarachnoid space over the frontal pole in the first year. Ventricles are usually normal or very minimally enlarged, maybe distinguished from subdural hygroma, subdural hematoma by the cortical vein sign, and usually resolves spontaneously by 2 years of age. So external hydrocephalus usually compensates by 12 to 18 months without shunting. So you are supposed to do a follow-up CT or an ultrasound to rule out abnormal ventricular enlargement. So this is what you have to know about external hydrocephalus. All right. So the same question. So the same question now, that what they have asked is what advice will I give to the mother? The treatment will always going to be observation and serial monitoring. You're not going to do a VP shunt or a CSF tap. That is going to be absolutely contraindicated. All that you have to do is to reassure the mother and to do a follow-up CT. So 6-year-old child underwent endoscopic third ventriculostomy for congenital hydrocephalus. But after surgery, the parents noticed that the child is having an excessive habit of excessive eating. So it is due to injury to, it is classically a hyper eating disorder or a hyperphagia, where you see it in hypothalamic dysfunction. So endoscopic third ventriculostomy complications. This is a very important slide. Hypothalamic injury can result in hyperphagia. Injury to pituitary stalk can happen, resulting in hormonal abnormalities, including diabetes insipidus, amenorrhea. Transient third cranial nerve or sixth cranial nerve palsies can happen. Injury to basilar artery, posicommunicating artery, cerebral artery, all of this can happen. Uncontrolled bleeding, cardiac arrest, traumatic basilar artery aneurysms. So all this can happen following ETV. So all these are important complications that can happen with ETV. So you have to be aware of them. All are true for spine surgery except. So this is regarding positioning. So prone positioning is likely the most common position in spine surgery, but is associated with distinct physiological changes. Yes, it is true. Optimal intraoperative surgical contour is critical for proper patient positioning. Yes. Jackson table system is the most commonly used surgical table or frame. Yes. Meralgia paresthetica is not an uncommon position. It is a very common position-related complication of spine surgery, and usually as a malignant course. So it is not uncommon. Okay, it is not uncommon. It is quite common, but it has a benign course. It actually usually resolves, so you don't have to worry about it. So ulnar neuropathy, brachial plexopathy can be caused by compression or overstretching. These are the most common upper extremity positioning related peripheral nerve injuries, but the risk for these complications may be reduced with intraoperative neuromonitoring and prompt repositioning. So what is very important is the complication related to the meralgia paresthetica. So that you have to keep in mind. It is very common. So this is a very important slide regarding the postoperative vision loss. Postoperative vision loss is very rare, but has been reported, and that's a potentially devastating complication after spine surgery. So risks include prone positioning, prolonged operative duration, high blood loss, intraoperative hypotension, male sex, comorbidities. So all these can cause. And similarly, risk for postoperative visual loss can be potentially reduced by avoiding direct ocular compression. By avoiding direct ocular compression, maintaining neutral cervical alignment, and keeping the patient's eyes above the level of heart with a 10-degree reverse Trendelenburg position. So all this can help you in preventing it. For trauma patients with unstable injuries, supine transfer onto the flat top Jackson table and then initiating the 180-degree rotation sequence may limit the unstable segmental motion. So what you have to remember here, the take-home message for you is always going to be post-operative vision loss is a significant complication that can happen, especially when there is no adequate padding over the eyes. So that can happen. So you have to be very careful in dealing with that scenario. So this is a very advanced question regarding robotic neurosurgery. So this is a teaching MCQ. So that is why it's very large. So most robots in commercial use comprise interacting mechanical and electrical systems, often integrating feedback from one or more sensors under the control of a computer that is programmed to guide the entire system through specific tasks. Yes, it is true. Robots can provide the ability to execute diverse sets of programmed instructions reliably and repeatedly, often with superhuman speed and accuracy. Robotic systems in neurosurgery have been used extensively for stereotactic pulses, mainly used for stereotactic, including electrode placement and biopsy. But contemporary machine learning techniques will likely lead to increasing levels of autonomy in surgical and neurosurgical robotics. So that is going to be the answer after excluding all these options. So robot is a machine that is going to be capable of autonomously executing set of programmed actions. So most robots will comprise an interacting mechanical and electrical systems, often integrating feedback from one or more sensors under the control of a computer that is programmed to guide the entire system through specific tasks. So they provide the ability to execute diverse sets of programmed instructions reliably and repeatedly, often with superhuman speed and accuracy. And a ubiquitous feature of industrial robots is the articulated robotic arm, a design feature that dominates contemporary robotic surgery, in part because many such systems are intended to function like the arms and hands of surgeon. Though this is not very often used in the Department of Neurosurgery, it has been there have been robotic systems. One such robotic system is called as ROSA, a robotic operative surgical assistant, ROSA, ROSA. So that is one thing that has been used in a few advanced centers in India. And contemporary machine learning techniques will likely increase the levels of autonomy in surgical and neurosurgical robotic systems. So that is what is the option after rolling out. So this is a very important question. All are true regarding brain retraction except. See, the retractor use is not secondary. Okay. The retractor use is secondary to the options are the retractor use is secondary to prioritizing of proper patient positioning, maximal exposure, appropriate arachnoid dissection, and can be assisted with techniques such as CSF diversion and stereotactic navigation. Or option B, that is modern parenchymal tubular retractors and endoscopic approaches can help to minimize brain retraction and parenchymal injury. Parenchymal injury secondary to brain retraction is common. So the answer is none of the above. So all the options are true. See, the first thing in neurosurgery is proper positioning of the patient. The patient should be positioned properly, allowing maximal bony exposure and appropriate amount of arachnoid dissection, CSF diversion, stereotactic navigation. All these are the primary objectives. Retractor use will always be secondary to all these prioritizations. And similarly, modern parenchymal tubular retractors and endoscopic approaches, they help to minimize the brain retraction and parenchymal injury. Yes, it is a true statement. And brain retraction is associated with secondary injury. So brain retraction can lead to parenchymal injury. Yes, that is also true. So after ruling all these out, the answer is option D. A 49-year-old male attends the emergency department complaining of headache and vomiting for the last 2 days. Now he has clumsiness in his left hand. There is no history of trauma. His GCS is 15/15. And the CT is showing you a right-sided acute subdural hematoma with a midline shift of 5 mm. Which one of the following would you perform next? See, the next that you can do is going to be a CT intracranial angio. So why a CT intracranial angio? Why a CT intracranial angio? Mainly to rule out a dural AV fistula. So mainly to rule out a dural AV fistula, then you have to do a CT cerebral angio. Then you have to do a CT cerebral angio. So what are the advantages of an endoscope in neurosurgery? Or all except. So it has a wide angle view, ability to look around the corners with angled endoscopes. It reduces retraction. It lacks binocular vision. So what is not true is it does not lack a binocular vision. So there are certain advantages to an endoscope. One, it is having a wide angle view, visualization at the site of surgery, and ability to look around the corners with angled endoscopes, yes, and increased area of visualization at the site of surgery. And it also reduces retraction of neurovascular. So it also reduces the retraction of neurovascular structures. Disadvantages: lack of binocular vision with current technology, occupying space in surgical corridor, occupy space in the surgical corridor, and necessity for an assistant or holder for endoscope to perform the bimanual surgery, lack of instrumentation to work through operative channel, learning curve for implementation. So all these are disadvantages with an endoscope. This image MRI is highly suggestive. You can see that in the pineal region there is going to be a large space occupying lesion. So this is characteristic of a vein of Gallant malformation. This is characteristic of a vein of Gallant malformation. So well circumscribed mass in the pineal region with various MRI signals from blood products is consistent with the diagnosis of vein of Gallant malformation. So in neonates, it has a tendency to present with high output cardiac failure, and it warrants an urgent treatment, especially endovascular treatment. So the abnormality depicted by the following angio. The angio image I couldn't add it here. So it happened at the basilar tip. So it was a basilar tip aneurysm. That is what was shown in the image. The superior hypophyseal artery, like I told you, is a branch of ophthalmic artery. This you have to remember. The inferior hypophyseal will be a branch of the cavernous, whereas the superior hypophyseal will be a branch of the ophthalmic. And a 56-year-old hypertensive male is having an intraparenchymal hemorrhage and an IVH. And the GCS is around 10, that is E2, V3, M5. So what is the next step in management? The next step in management is going to be a EVD placement. So that will be the next logical step. Because IVH is going to deteriorate because of an obstructive hydrocephalus, so it is better to do a EVD. So regarding EVD, the very important thing that you have to remember is the coccus point. The coccus point has been described as 11 centimeters superior from the nascion and 3 centimeters lateral to the midline. So you do a twist drill and the trajectory, you aim it ipsilateral to the medial canthus and ipsilateral external auditory canal in the AP plane. So you may direct it medially and you advance it around 6 to 7 centimeters from the skin surface, and the front lance will be encountered, and then you tap it. You put the external ventricular drain and then you drain it. And a comatose patient who suffered a traumatic car accident had a mid-position pupils that does not respond to light. What is the most localizing causative injury for his pupillary abnormality? So here the pupils are in mid position and they do not respond to light. So the answer is going to be a midbrain injury. A bilateral midbrain tegmental injury is going to result in a non-reactive pupil in the mid position. So pupillary responses can help in localizing inducing lesions. Like midbrain tegmental injury can result in fixed mid-position pupils. Pontine lesions are associated with pinpoint pupils. Global cerebral injury, small but reactive pupils. Diencephalic injury, again small but reactive pupils. Injury to oculomotor nerve is usually going to cause a fixed dilated pupil on the ipsilateral side. Unilateral fixed dilated pupil, mainly because of uncal herniation or compression on the third nerve. Okay. A 4-year-old girl presents to the ER after being involved in a high-speed motor vehicle accident. She complains of neck pain but is otherwise neurologically intact. The CT image was taken and it is showing a synchondrosis fracture of the axis. That is the C2, atlas axis. The second cervical vertebra is being fractured. That is what is shown. So how many primary ossification centers are normally seen in axis? This is a very important question. This has been asked previously. The answer is number 5. There are totally 5 primary ossification centers in axis. So 2 in the vertebral arches, 1 in the vertebral body, and 2 along the dens. So this is the normal thing. So 5 primary ossification centers. So the following statements that concern the spinal cord. The spinal cord has a cervical enlargement for brachial plexus. The spinal cord possesses spinal nerves that are attached to the cord by the anterior and posterior rami. In adult, the spinal cord usually ends inferiorly along the lower border of 4th vertebra. The ligamentum denticulum anchors the spinal cord to pedicles of vertebra. So the statement that you have to identify here is the true statement. The answer will be the spinal cord has a cervical enlargement for brachial plexus. So what is important is the ruling out the options. See, the spinal cord possesses spinal nerves. They are attached to the cord by the anterior and posterior nerve roots. And in adults, the spinal cord will usually end in the lower border of L1. Okay. And denticulatum will anchor the spinal cord to the dura mater along the each side. It is not going to attach it to the pedicles. The central canal will contain CSF, which communicates with the 4th ventricle. So all these are true statements. So what I have discussed here are the true statements. The options that were given as B, C, and D were wrong. So the answer will be option A. The following statements true regarding spinal cord. The anterior and posterior gray column on the 2 sides are united by white commission. That is the wrong statement. It is going to be gray commission. The terminal ventricle is nothing but the expanded lower end of the 4th ventricle. The large nerve cell bodies in the anterior gray horns give rise to alpha type of efferent nerve fibers in the anterior roots. And the substantia gelatinosa group of cells are located at the base of each gray column. So here the answer is option C. So like I told you, option A, it is the gray commissure. Terminal ventricle is nothing but the expanded lower end of central canal. It is not the 4th ventricle. Here the option B is showing you 4th ventricle. And similarly, substantia gelatinosa is a group of cells located in the apex of each posterior gray column, not the anterior. So it is located throughout the length of the spinal cord. So all these are wrong statements. What is true was the option C. That is, the large nerve cell bodies in the anterior gray horns gives rise to efferent nerve fibers in the anterior roots. So dorsal roots are sensory, ventral roots are motor. So that can help you in marking the answer as option C. That is the Bell-Magendie law. This is a very important question. The most common incomplete spinal cord injury will be the central cord syndrome. This is very important. Common site for extradural hemorrhage, the answer will always be temporoparietal. This is very important. And the one more point, the lucid interval. Textbook description, brief post-traumatic loss of consciousness following initial impact, followed by some period where the patient is fully conscious. That is what is called as the lucid interval. And then patient slips into coma, contralateral hemiparesis, ipsilateral pupillar dilatation, all this can happen. So this is what is the classical description of a lucid interval, seen in only 10 to 20% of patients. So there is one more phenomenon is called as the Kernowan's notch, which is very important. It is a false localizing sign where normally you get a left-sided EDH, there will be weakness on right side. Whereas in Kernohan's phenomenon, you have a left-sided EDH, the weakness will be on the same side. It is what is called as Kernohan's phenomenon or Kernohan's notch phenomenon, which is a false localizing site. And the most common site is always be temporal or temporoparietal. And the force required to sustain a skull fracture is surprisingly small. For example, fall from a standing position or even a single blow to the head, especially in boxers, those who undergo boxing. So they have a tendency to have a concussion, and sometimes it can be a small extradural hemorrhages also. So that is very commonly observed in long-term boxers. And early recognition and treatment is likely to result in full recovery. Yes, it is true. So in preparation for a ventriculostomy catheter, a resident measures a 2.5 centimeters from the midline and 1 centimeter anterior to the coronal suture. So what is the point that he is measuring? The point that he is measuring is the coccus point. So what should have been added here is the distance from the nasion. That is around 11 centimeters. So 2.5 centimeters from midline and 1 centimeter anterior to the coronal suture, which is also going to be the coccus point. So this is very important. And Keen's point will be placing it through the posterior parietal region. All right. So neuroblastomas have a tendency to present with spinal cord compression, Ornstein curse, and diarrhea. So what is this Ornstein curse? Ornstein curse is nothing but this person, Ornstein was cursed by, I think it was Greek mythology, was cursed in Greek mythology by some Greek god that if he wants to stay alive, if he wants to stay alive, he has to breathe. And if he sleeps, he cannot breathe. So that is what is the Ornstein curse. So if he has to stay alive, he has to stay awake. If he sleeps, he will stop breathing. So that is what is the Ornstein curse. So what is this? It is nothing but the autonomic control of respiration is lost. So that is what is Ornstein curse. So diarrhea, it can happen because of the vasoactive interstitial peptide secretion by the tumor. And similarly, it can result in spinal cord compression. So all this can happen with neuroblastomas. A 7-year-old male presents with complaints of headache, vomiting, and ablution. The patient's neurological examination is significant for papilledema, paralysis of upward gaze, and mild ataxia. So lots of clues have been given here. And on MRI, pineal region lesion you can identify. So what is causing this? Upgaze palsy. So dorsal mid compression on the superior colliculus results in the upgaze palsy. So that is why the patients tend to get this upgaze palsy. Okay. So this is what you call as Parinot syndrome. Compression on the superior colliculus resulting in paralysis of upgaze, convergence retraction nystagmus, and near light pupillary decision. So this is very, very, very important. I have described it very clearly in the classes, in the videos, and I hope you will not make mistakes out of Parinot syndrome or pineal region tumors. This is very important. Pineal region, pituitary tumors, all these are very important topics. A 7-year-old male presents to you with complaints of headache, vomiting, and ablution. The patient's neurological examination is significant, is showing papilledema, paralysis of upgaze, and mild ataxia. So again, you are describing Parinot syndrome. So what is the least possible differential diagnosis? So in children, the most common diagnosis will always be germ cell tumors. And then pineoblastomas can happen. Germinoma, which is a non-germ cell tumor, is a very good tumor that happens in this region. It has a very good prognosis. And what is not true is chordoma. Chordoma happens in adults. It is not a pediatric tumor. All right. So hyponatremia can be caused by direct cause of SAH from which of the following aneurysms? So SAH due to any cause can result in hyponatremia, but the most common will always be anterior communicating aneurysm. So keeping in mind, we can put it as anterior communicating aneurysm. Otherwise, direct cause, it can also happen because of anterior communicating. Why? Because of irritation of the hypothalamus. So it can result in hyponatremia. So the cranial nerve most sensitive to radiation will be the optic nerve. So even the most sensitive to radiation will be the optic nerve and the optic chiasm, even with a single fraction dose of around 8 grays. So in the order of frequency, you have to remember 12, 11, 10, 5, and 6. So all these is the order that you have to remember. The recurrent laryngeal nerve can be injured after radiation therapy for breast cancer or lung cancer. Therefore, in anterior-cervical discectomy and fusion causes, patients with a high risk history of radiation in these areas should be briefed of the risk of hoarseness and vocal changes after surgery. Okay. Not recommended treatment for fibrodysplasia. So what is not recommended is radiotherapy because it is very restrictive. It is not radiosensitive. Most common location of spinal tumors. So the answer is extradural. Why extradural? The question they are asking is the essentially most common spinal tumor. You have to remember the most common spinal tumor will always be metastasis. So metastasis is going to be extradural. Lymphoma can occur at all of the following sites. So it can happen in extradural or intradural extramedullary or intramedullary. It can happen at all sites. So the answer is all of the above. Lymphomas are not very common in the spinal cord. All right. All are primary extradural spinal tumors except is it a teratoma, is it a chondrosarcoma, a giant cell granuloma, or is it a chordoma? So teratomas are not extradural; they are going to be intradural, and even teratomas they are not very common in the spinal cord. Most common cause of pediatric hydrocephalus. So you remember that the most common cause of pediatric hydrocephalus is going to be intraventricular hemorrhage resulting from premature birth. So 5 most common causes based on the percentage wise, it is going to be IVH from premature around 22%, myelomeningocele around 16%, posterior fossa tumor around 11%, arterial stenosis around 8%, and congenital communicating hydrocephalus around 8%. So the most common based on this statistics is going to be IVH from premature birth. For chronic subdural hematoma, which is the least common surgical option. So you can do a twistal craniotomy or a mini craniotomy or a burr hole craniostomy. But what we do not do commonly is a deep compressive craniotomy. Why? Because it is going to be liquid. The blood will be liquid thin. So you can do 2 holes and you can evacuate the clot. So indication for neurosurgery during pregnancy. So in pregnancy, symptomatic brain tumors, ICH, progressive spinal cord pathology, all of this will be indications for surgery. So anything that is going to cause morbidity or mortality to the mother, then it is your duty to save the mother first. So it can happen, this scenario you can encounter very much. So it is quite rare, the need for neurosurgery in pregnancy, but it can happen with intracranial hemorrhage, traumatic brain injury, symptomatic brain injury, brain tumors, or with progressive spinal cord pathology. So if it's going to be some trivial lumbar canal stenosis, you can ignore it, but not a very large tumor is going to have significant impacts on the mother's life. So you have to intervene in that scenario. And no anesthetic agents have been proved to be teratogenic. So you have to be, you can deliver the baby even safely. All are the diagnostic criteria for pseudotumor cerebri. See, pseudotumor cerebri, the term pseudotumor cerebri is not used nowadays. Nowadays, we use the term idiopathic intracranial hypertension, and signs and symptoms of raised ICT are seen. The ventricles are normal to small size and there are no intracranial mass. Increased CSF pressure without chemical or cytological abnormalities. All these are true except generalized seizures. Why? Because seizures are not the presentation for pseudotumor cerebri. So the modified Dante's criteria, you have to remember this. Signs and symptoms of raised ICT, no localizing signs other than sixth nerve palsy, increased CSF pressure with no chemical or cytological abnormalities. That is, you send the CSF for analysis, it will be normal. Normal to small ventricles and no intracranial mass. So all these are the modified criteria. The most common symptom for colloid cyst. The most common symptom for colloid cyst will be headache. Headache will be the most common symptom. Even though you have a tendency to mark this drop attack, don't do that. Drop attacks are common in colloid cyst, but headache will be the most common symptom. Which among the following tumors arise from the remnants of notochord? From the remnants of notochord, you will get chordomas. So chordomas are primary malignant tumor, usually arising from the clivus or sacrum with a high recurrence rate and histologically characteristic physalliferous cells containing intracellular mucin Generally slow growing, radio resistant, and treatment of choice will always be en bloc resection as much as possible. With the proton beam radiation may be helpful. Brown sequence syndrome is most commonly due to an intradural extramedullary tumor. This is very important. You have to remember this. Brown sequence syndrome, this that is the intradural extramedullary tumors, that is the spinal schwannomas and meningiomas, slow growing benign extramedullary tumors which compress on the spine, typically present with slow progressive signs of spinal cord compression. They tend to arise eccentrically, lying on one side of the spinal cord, either dorsally or ventrally. The eccentric tumor position results in asymmetric cord compression with higher incidence of Brown sequence syndrome. So what are the findings of Brown sequence syndrome? Ipsilateral involvement of corticospinal and dorsal columns with contralateral involvement of the spinothalamic tract. So on the same side, the corticospinal tract and the dorsal columns are involved, whereas the opposite side, spinothalamic tract is involved. So this is the classical picture for Brown sequence syndrome. Which among the following is not an intramedullary tumor? So spinal hemangioblastoma, ependymoma, neurofibroma, or astrocytoma. The answer will be neurofibroma. Neurofibromas are extramedullary intradural. The most common organism causing postoperative discitis will be staph epidermidis. This is a very, very, very important question. The next slide is very important. Staph aureus is the most common organism isolated from discitis. But after surgery, that is post-operative discitis, the answer will be staph epidermidis. Pseudomonas aeruginosa may be more common in IV drug abusers. H. influenza in juvenile discitis. So all these are very important. The most common will always be staph aureus. So after surgery, post-operative, it is going to be staph epidermidis. Pseudomonas aeruginosa is more common in IV drug abusers. And then comes the H. influenza for juvenile discitis. Which among the following tumor is associated with medically intractable seizure? Say, regarding medically intractable seizure, the most important thing that you have to remember is this embryoblastic neuroepithelial tumor, DNET. So this is the most, this is one of the most common tumors causing intractable seizure. They are usually very tiny tumors. They are WHO grade 1 tumors. They have a very good prognosis, but they usually present to you with seizures. So herniated lumbar disc is most common at which level? This is statistically L4 and L5, the L4, L5 and L5S1 are very close, but some books tell you that L5S1 is a very common level. So based on that, the answer is L5S1, but statistically both L4 and L5 and L5S1, both these are very common levels for lumbar disc herniation. L5S1 has a little bit edge. Why? Because it is a mobile spine. So it has a tendency to present with disc pathology more common. Lumbar canal stenosis, L4, L5 will be the most common level. Lumbar canal stenosis, this L4, L5 for sure. And lumbar disc prolapse, it will be L5S1. So with that, the discussion on the slides on the MCQ parts is complete. And I hope the session was very useful to you, and a few things that you have to do in the last few days before your exams, before preparing for the exams, is one thing. First and foremost, you have to remain very calm. You have to stay focused. You have to stay calm. Most of the questions you will know the answers. Only thing is you have to rule them out and apply your knowledge and solve it. And don't think anything beyond the exam date. For now, the next 7 days is very important to you, and focus on what is in hand, and that will be more than useful for you. So, and while solving MCQs, solve MCQs with confidence. Try to attend at least 85 to 90% of questions if the paper is going to be easy or a moderate one. And if it is going to be very tough, then you can have an edge of around 80%. Around 80% of questions, at least you have to attend if you want to be in contention for a very good rank. So at the bare minimum, you have to attend 85 to 90% if it is going to be an easy paper or a moderate paper. If it is going to be a tough one, maybe some 2-3 more questions you can leave. And the neurosurgery part, I believe the concepts are very clear to you. You should have revised most of the notes and the topics by now. And I wish you all a very good success and meet you as neurosurgeons in near future. See you. So with this note, I am ending the session. Bye-bye.